1, 2,
and review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the ECMO people check? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, usually when we think about breathing, there's this expectation of, I don't know, automatic perfection, like a metronome.
Right. It's totally involuntary.
Yeah, you inhale, oxygen goes in, you exhale, carbon dioxide goes out, and the machine just runs.
It's invisible to us, really, on a day-to-day basis.
Clean, reliable, and just completely in the background.
And it's comforting, you know. We like things to be predictable, especially our own physiology.
Exactly, but then you step onto the floor of the intensive care unit, and suddenly that perfect invisible metronome is just broken.
Completely broken.
You're looking at a respiratory landscape that can turn deadly in, what, a matter of minutes?
Oh, easily. I mean, it is the absolute definition of a high-stakes physiologic collapse.
Okay.
In the ICU, your margin for error with the respiratory system is essentially zero.
So welcome to another deep dive. Today, our mission is entirely custom-tailored for you, whether you're a strong ICU nurse looking to elevate your practice, or you're just learning to think like an elite intensivist.
Yeah, we are stripping away the fluff today.
Aggressively applying the 80-20 rule to lower respiratory disorders. We're zeroing in on that small percentage of critical knowledge that actually drives your bedside decision-making.
Right, the stuff that impacts exam performance and, most importantly, patient survival.
So we are focusing exclusively on what will kill your patient first, what requires your immediate action, and how to anticipate a crisis before those alarms start blaring.
To do this, we're going to explore the three major pillars of acute respiratory failure.
Right.
So we have an alveolar infection, which is severe pneumonia. We have a mechanical failure, tension pneumothorax. And finally, a vascular or, perfusion failure, which is pulmonary embolism.
Okay, so let's unpack this, starting with the alveolar threat severe pneumonia. I mean, it's the fourth leading cause of death worldwide.
Yeah, a massive driver of ICU admissions.
So if we're thinking like an intensivist here, what is the absolute core of this disease?
Well, the core issue is an acute infection of the lung parenchyma, the functional tissue of the lungs, right? But the most critical distinction you have to make at the bedside is classifying where it actually came from.
Like where they caught it.
Exactly. Is this community-acquired pneumonia known as CAP? Or is it hospital-acquired or ventilator-associated pneumonia HP or VAP?
But why is that distinction the priority? I mean, an infection is an infection, right?
Well, not to your antibiotics.
Ah, right.
That classification dictates your entire empiric antibiotic strategy. If a patient gets sick at home, we're usually dealing with standard, predictable bacteria. But if they develop pneumonia after 48 hours in the hospital or on a vent...
You got the nasty stuff.
Exactly. You immediately have to suspect multidrug-resistant bugs, the heavy hitters like MRSA or Pseudomonas. If you treat HAP with community-level antibiotics, your patient will not survive.
Wow. Okay, so let's walk through what is actually happening in the tissue, the pathophysiology. The trigger is a pathogen that somehow bypasses the airway's defense mechanisms.
Right.
The body senses the invader and just triggers this massive inflammatory response.
And that inflammation is really where the trouble starts. So inflammation increases vascular permeability, the capillaries dilate, they get leaky.
Allowing neutrophils and fluid to just pour directly into the alveoli to fight the infection.
Exactly. Your white blood cells are swarming the area.
And all that fluid and cellular debris pooling in the air sacks. That's what we call consolidation.
Right.
The analogy I always use for consolidation is imagine a fluffy, air-filled kitchen sponge.
Okay, I like this.
That's a healthy lung. Now, soak that sponge in wet, heavy concrete and let it harden. Air simply cannot squeeze into it anymore, so gas exchange completely stops in that specific area.
That is a brilliant way to visualize it. And that concrete sponge dictates exactly what you'll find on your assessment. Because the alveoli are full of fluid, oxygen transport is totally impaired.
So the body's immediate compensation is tachypnea.
Right, breathing faster to try and get more air. Your early classic signs are going to be fever, chills, a productive cough with purulent or even rust-colored sputum, and pleuritic chest pain.
Wait, I want to pause on the fever part. Because in older adults, you often don't see that classic high fever, right? I mean, I've seen elderly patients admitted who are actually cold.
Yes. And I am so glad you brought that up because that is a massive clinical pearl.
It's a huge exam trap, too.
It really is. You might expect a high fever, but the elderly often present with hypothermia.
Because of immune senescence.
Exactly. Their aging immune system simply cannot mount a robust pyrogenic or fever-inducing response. Instead, what you will see is a sudden change in mentation. They become confused or stuporous.
So the confusion isn't necessarily dementia or a stroke.
No.
It's their brain starving for oxygen because of the pneumonia.
Exactly. Hypoxia makes the brain profoundly confused. Now, if you take your stethoscope and listen over that concrete sponge we talked about, you're going to hear fine or coarse crackles as air bubbles through the fluid.
And bronchial breath sounds in the periphery, right, where they definitely shouldn't be.
Right. And you'll assess for egophony.
Egophony is when you have the patient say the letter E, but through the stethoscope, it actually sounds like an A, right?
Correct. And the why behind that is just simple physics. Sound travels faster and louder through a solid or a liquid than it does through air.
Ah, so that consolidated fluid-filled tissue transmits the higher frequencies differently.
Exactly, changing the E to an A. You'll also feel increased tactile fremitus, which is more vibration on their back when they speak, for the exact same reason.
Okay, so 80 PIE time. As a nurse, your assessment is recognizing the hypoxia. You hear the crackles. Your diagnosis is impaired respiratory function, so your brain shifts into planning mode.
Right. You want clear breath sounds, normal SpO2, and to get them a febrile.
Right. So from a diagnostic standpoint, you're anticipating a chest X-ray to visualize the infiltrates. You're going to check an ABG and arterial blood gas to definitively see the hypoxemia, and you'll look at the CBC.
Right. And on that CBC, you are looking for leukocytosis, usually a white blood cell count over 15,000. But more importantly, you are looking for a shift to the left.
Meaning an increase in immature white blood cells, the BAMs.
Exactly. The infection is so severe that the bone marrow is basically panicking. It's kicking out premature, untrained neutrophils just to get bodies on the battlefield.
Wow. Okay, so let's talk priority bedside actions for implementation. Your patient is hypoxic, breathing fast. Your immediate first steps, you apply oxygen and elevate the head of the bed past 30 degrees to maximize lung expansion.
Yes.
Next, you need to identify the bug. You're obtaining sputum cultures and drawing blood cultures if they're seriously ill.
But here is the golden rule of critical care. You get those cultures before you give the antibiotics.
Right, absolutely.
Because if you pump the patient full of broad-spectrum antibiotics first, the bacteria will hide, the cultures will come back negative, and you won't know what you're actually fighting.
But you never delay the antibiotics if you can't get the culture right.
Never. If it's taking too long to get the sputum, you just start the IV antibiotics anyway. Delays in empiric therapy directly increase mortality.
So for CAP, you're usually hanging macrolides like azithromycin or beta-lactams.
Right, and for HAP, you are pulling up the big guns, vancomycin or linezolid for MRSA, plus something for Pseudomonas.
What about fluids? You want to hydrate them to thin out all those thick secretions, right? Like 2 to 3 liters a day.
Yes, usually. And you have to think like an intensivist here. If your pneumonia patient also has a history of congestive heart failure and you aggressively pump them full of IV fluids,
You'll send them straight into pulmonary edema.
Exactly. You fix the pneumonia but drown them in the process. It's a very delicate balance.
Okay, so evaluating deterioration. How do we know our patient's getting worse? What are the red flags that say, we're losing this fight?
The patient is getting worse if their respiratory rate continues to climb. That means they're tiring out. If their blood pressure starts falling, that is a massive red flag.
Because the localized lung infection has now leaked into the bloodstream.
Exactly, causing systemic vasodilation. They are entering septic shock. That requires an immediate escalation, calling a rapid response for vasopressors and potential intubation.
All right, let's lock in the 5 critical takeaways for severe pneumonia. Number 1, the core pathophysiology. Fluid and cellular debris fill the alveoli, creating a physical block to gas exchange.
Number 2, key assessment findings. Localized crackles, egophony, and purulent sputum.
Number 3, the most dangerous complications. Acute respiratory failure and sepsis.
Number 4, your priority nursing action. Obtain cultures before starting antibiotics, but do not delay treatment.
And number 5, the most important treatment. Empiric antibiotics specifically targeted to community versus hospital-acquired bugs.
So your one-sentence clinical picture is a patient with a fever, productive cough, pleuritic chest pain, and localized crackles on auscultation.
And that intensivist mantra. If you see new confusion and hypothermia in an elderly patient, think hypoxia from pneumonia and immediately check an SpO2 and a chest x-ray.
Perfectly summarized.
Awesome.
Now, if we connect this to the bigger picture, we are moving from a fluid problem inside the alveoli to a mechanical air problem outside the lung.
Okay, our second pillar, tension pneumothorax.
Right. And I want to be clear here. While pneumonia might take days to kill a patient, a tension pneumothorax can kill them in minutes by basically crushing their cardiovascular system.
Okay, let's get the 80-20 overview. A pneumothorax is when air enters the pleural space, that cavity between the lung and the chest wall. But a tension pneumothorax is when that air enters and cannot escape.
Exactly.
It causes a complete collapse of the lung on that side and physically pushes everything in the chest over.
Right. The pathophysiology usually starts with a trigger. So blunt chest trauma,
Yeah.
barotrauma from a mechanical ventilator pushing too much pressure, or even a clamped chest tube.
So what's the physiologic change?
It's a one-way valve effect. Every time the patient inhales, air is sucked into the pleural space. But when they exhale, the tissue flap closes. The air is trapped.
So pressure just builds and builds with every single breath.
Exactly. And that decompensation is where it gets deadly. The increasing intrapleural pressure becomes so massive that it pushes the heart, the trachea, and the great vessels to the unaffected side.
The mediastinal shift.
Yes.
Now, here's where I have to push back, or at least ask about a huge trope.
Oh, I know where this is going.
Yeah, on every medical TV show, the doctor looks at the patient's neck, yells, "tracheal deviation," and grabs a huge needle to stab them in the chest. Is the trachea shifting really the first thing we look for?
I am so glad you brought that up. That is a massive misconception and a very dangerous exam trap for nursing students.
Really?
Tracheal deviation is an extremely late sign. It means the pressure is already catastrophic. If you wait to see the trachea physically move across the neck, your patient is likely already in cardiac arrest.
Wow. So what are the early signs we should be hunting for during our assessment?
Severe sudden dyspnea, extreme agitation. I mean, they literally feel like they are suffocating. Marked tachycardia, profuse diaphoresis, and completely absent breath sounds on the affected side. You listen, and it's just silence.
Let's talk about the hemodynamics because it's fascinating. It's a lung problem, but it causes a cardiovascular death. Why?
Wow.
Because that massive positive pressure in the chest completely compresses the superior and inferior vena cava, right?
Exactly. The vena cavae are low-pressure vessels bringing blood back to the right side of the heart. If you crush them, blood can't return.
So venous return, which is your preload, drops to zero.
Yep. And if the heart has no blood to pump, cardiac output plummets to zero, your blood pressure free falls into profound shock.
So giving them IV fluids or vasopressors at this point won't save them.
No!
I mean, the heart is fine. It's just empty.
Precisely. You can pump them full of epinephrine, but if there is a mechanical kink in the hose, nothing works until you unkink it.
Okay, so 80 PIE. As a nurse, you recognize the extreme agitation, you hear the absent breath sounds, and you diagnose inadequate cardiac output and hypoxemia.
Right.
You watch the blood pressure tanking. This isn't a notify the provider and wait for a chest x-ray moment, is it?
Absolutely not. You do not wait for an x-ray. This is a life-threatening emergency. Your first action is to assess the airway and apply high-flow oxygen.
Right.
But your immediate next step is preparing for an emergency needle decompression. The provider will insert a large bore needle into the second intercostal space, mid-clavicular line, to vent that trapped air.
And as the nurse, you were right there, ready to evaluate if it worked. You're listening for that literal audible rush of air like opening a shaken soda bottle.
Yeah, exactly like that.
And you'll see an almost instantaneous improvement in the heart rate and blood pressure because the vena cava opens back up.
And right after that needle buys you time, you are assisting with a chest tube insertion connected to a water-sealed drainage system to permanently fix the leak.
You mentioned clamped chest tubes earlier. That's a huge ICU pearl, right?
It is. Clamping a chest tube in a patient who still has an active air leak will cause a tension pneumothorax.
Because the air has nowhere to go.
Right. So if you have a patient with a clamped tube who suddenly gets tachycardic, drops their blood pressure, and is gasping for air, your immediate independent nursing action is to unclamp that tube immediately.
Just unclamp it.
Yes. Never clamp a chest tube unless you are specifically directed to for a brief leak test or changing the system.
All right, let's do our rapid-fire mental checklist for tension pneumothorax. Number 1, the core pathoec. Trapped air creates positive pressure, shifting the mediastinum and crushing venous return.
Number 2, key assessment. Absent breath sounds on one side with severe tachycardia and sudden hypotension.
Number 3, the most dangerous complication, inadequate cardiac output, leading to cardiovascular collapse and death.
Number 4, your priority nursing action. Recognize the shock and prepare the provider for immediate needle decompression.
And number 5, the most important definitive treatment, chest tube insertion to water seal drainage.
So your one-sentence clinical picture. A trauma or ventilated patient who suddenly develops severe dyspnea, extreme agitation, absent unilateral breath sounds, and a tanking blood pressure.
And the intensivist mantra. If you see a sudden drop in blood pressure, absent breath sounds, and jugular vein distension in a patient on a ventilator, think tension pneumothorax and prepare for a needle.
Contrast that quickly with cardiac tamponade, which also has JVD and low blood pressure, but gives you muffled heart sounds instead of absent breath sounds.
That distinction is crucial. Okay, so this raises a really important question. We've covered fluid filling the alveoli, we've covered air trapped outside the lung, but what happens when the actual blood supply to the lung is the problem?
That brings us to our third and final pillar, the perfusion threat. Pulmonary embolism and its deadly consequence, cor pulmonale.
The overview here is just stark. A PE is a blockage of the pulmonary arteries by a thrombus, usually a blood clot originating from a deep vein thrombosis in the leg.
Though it could be a fat embolus from a broken bone or even air.
Right, and 10% of patients with a massive PE die within the first hour.
The pathophysiology usually traces back to Virchow's triad. So venous stasis from immobility, endothelial injury from surgery or trauma, and hypercoagulability.
A DVT forms, breaks off, and travels up through the right side of the heart, shooting directly into the pulmonary artery where it just gets wedged.
Exactly. To visualize this, think of a massive saddle embolus, like a jackknifed semi-truck, right at the exact fork of a major highway.
Right.
It instantly blocks all traffic trying to go to both the left and right lungs.
And what happens when you block a major highway? You get a massive backup of cars. In the body, those cars are blood volume. That blood slams backward into the right ventricle.
And the right ventricle is a thin-walled chamber designed to pump against low pressure. Suddenly, it has to pump against a brick wall.
The right ventricular afterload spikes.
Exactly, leading to acute right heart strain and failure, which we call cor pulmonale.
And meanwhile, the lungs are still breathing in oxygen, but there's no blood arriving to pick it up.
Precisely. That is called alveolar dead space, or dead space ventilation. You have ventilation, but zero perfusion. The body's immediate compensation is severe to chimney breathing incredibly fast to try and fix a hypoxia that cannot be fixed with just more air.
So your early assessment finding, the most common symptom by far, is a sudden, unexplained onset of dyspnea. They are fine 1 minute and gasping the next.
Right. They might also have chest pain and a cough. But the late dangerous findings of a massive PE are sudden hypotension, a change in mental status, and that classic feeling of impending doom.
Diagnostics are vital here, and there are some traps. You might see a D-dimer blood test ordered. A D-dimer measures cross-linked fibrin fragments, basically the garbage left over when the body tries to break down a clot.
Yes, and here's the trap. A normal negative D-dimer reliably rules out a PE, but an elevated D-dimer does not prove a PE.
Because any inflammation, an infection, or recent surgery can elevate a D-dimer. Right.
Exactly. It is highly sensitive, but not specific. The absolute gold standard diagnostic is a spiral CT scan of the chest with contrast, called a CTA. You will also look at the troponin and the BNP brain natriuretic peptide.
And just to clarify, we usually think of troponin and BNP for left-sided heart attacks or heart failure. Why are we checking them for a lung clot?
Because as that right ventricle gets stretched out and crushed by the backup of blood, the muscle fibers actually tear, releasing troponin, and the overstretched heart releases BNP. It proves the right heart is failing.
So ADPIE in nursing actions. Your patient suddenly can't breathe and their oxygen saturation is dropping. You diagnose impaired gas exchange. Your first action, you apply high-flow oxygen, you elevate the head of the bed, and you mandate strict bed rest.
Right.
Why bed rest? Because if there are more clots in their legs, you don't want them walking around and breaking another one loose.
Exactly. Your next priority is medications, specifically immediate anticoagulation. We are usually reaching for subcutaneous low molecular weight heparin like enoxaparin.
Why enoxaparin over standard 5E unfractionated heparin?
It's a safer profile, it's more predictable, and critically, you do not need to constantly draw blood to monitor APTT levels like you do with an IV heparin drip.
Oh, that makes sense.
You will likely start them on an oral anticoagulant like warfarin at the exact same time, which takes days to reach therapeutic levels using the enoxaparin as a Brit.
But anticoagulants just stop the clot from getting bigger. They don't dissolve the jackknife semi-truck. If the patient is literally crashing in shock from massive PE, what do we do?
That is when you escalate to fibrinolytics like TPA or Activase. These are the clot busters.
Right.
They carry a massive risk of severe bleeding, but if the patient is dying from right heart failure, you have no choice but to dissolve the blockage.
Okay, let's run the final mental checklist for pulmonary embolism.
Yeah.
Number 1, core patho. A thrombus blocks pulmonary perfusion, causing dead space ventilation and acute right heart strain.
Number 2, key assessment. Sudden unexplained dyspnea, chest pain, and feelings of impending doom.
Number 3, most dangerous complication. Cor pulmonale, which is right ventricular failure leading to cardiac arrest.
Number 4, priority nursing action. Enforce strict bed rest, apply oxygen, and prepare for immediate anticoagulation.
And number 5, most important treatment. Low molecular weight heparin or fibrinolytics if the PE is massive and hemodynamically unstable.
Your one-sentence clinical picture. A post-operative or immobile patient who suddenly experiences acute shortness of breath, pleuritic chest pain, and extreme anxiety.
And your intensivist mantra. If you see sudden dyspnea and hypotension in a patient with a known DVT, think massive PE causing right heart failure and prepare for immediate fibrinolytics.
Spot on.
So, when we step back and look at these 3 pillars, pneumonia, tension pneumothorax, pulmonary embolism, what is the ultimate intensivist mindset?
It's realizing that airway, breathing, and circulation are not separate silos. They are intimately, violently connected. A fluid problem at the alveolar level, an air pressure problem at the pleural level, or a blood clot at the vascular level. All of them ultimately cascade into a cardiovascular collapse. You can't just treat the lungs, you have to protect the heart.
Incredible. Before we wrap up, I want to leave you with one final provocative thought from our source material on lower respiratory disorders, specifically looking at lung cancer.
Oh, this is a fascinating area.
Yeah. We usually think of a lung tumor purely as a structural mass, right? Something that physically blocks an airway. But sometimes these tumors cause something called paraneoplastic syndrome.
It is one of the most fascinating biological hijacks in medicine. The cancer cells mutate and start acting like rogue endocrine glands.
Exactly. They actively secrete hormones directly into the bloodstream, causing systemic conditions like SIADH, where the body retains massive amounts of water, or Cushing syndrome from excess cortisol.
It's wild.
So here's the thought to ponder. Could a patient's mysterious sudden hormonal imbalance or a strange drop in sodium actually be the very first hidden sign of lung cancer screaming at you before a tumor is ever even large enough to be seen on a chest X-ray?
It is a brilliant reminder that in critical care, the root cause is rarely the most obvious symptom.
Definitely. We want to thank you for joining us on this custom-tailored deep dive. Take this intensivist knowledge, apply that 80-20 rule, and bring this critical thinking directly to your next shift.
Because when that perfect invisible metronome of breathing suddenly breaks, you now have the tools to see exactly which gear is jammed, why it's jammed, and exactly how to fix it.
Catch you next time.